Send request.
Okay.
Okay.
Let me just share my screen again. Okay. Okay, everybody, thank you so much for joining us. We will be presenting on the on more information to understand really what rescheduling of cannabis to a Schedule 3 product or substance might look like. So the presentation is by the Pharmacist Cannabis Coalition of California. We are a nonprofit organization, and we aim to really educate the general public as well as practitioners on the use of medical cannabis and the safety and efficacy of it. So on our panel today, again, we're going to go over what it looks like for the rescheduling of cannabis. And our panel today, we've got, and this is our panel, as you can see here. And we're going to start with our first question. And our first question is, what are the current regulations for processing and dispensing a Schedule 3 medication? So I'm going to pass this one to Paul. And Paul, I'll have you go over it for us. And you might be on mute, so you might need to unmute, Paul. Let me see.
Wonder if Paul's here yet. He seems
no, he's here. No, he's here. He's just on mute. Yeah, he's here. He's just on mute. Oh, there's Paul.
Okay, Cody, can you hear me?
Yep, I can hear you, Paul. You're good to go.
Can you hear me?
Yes, we can hear you.
Thank you.
Yeah.
All right, sorry about, I'm working with a new computer, and I'm like you, Leah, we're trying to figure it out. All right, bottom line I want to start with is 1914, Harrison Narcotic Act. Under treaties that the United States entered with people around the world, we had narcotics controlled. I mentioned this only because of narcotics, not barbiturates, not hallucinogens, et cetera, et cetera. The way we managed this was through taxation. And every bottle of narcotic that the pharmacy received got a taxation stamp on it, and that showed that they were being controlled by the Department of Treasury. What happened in 1970 was the Controlled Substances Act was passed, and a number of drugs were put into the act, and all as a result of the emergence of LSD and other hallucinogens. Historically, marijuana, because of the LaGuardia report in 1938, considered marijuana as a dangerous drug, not to be touched, and was classified with heroin and other drugs such as that. Along come 1970, and the new act included scheduling of various controlled substances, Schedule 1, 2, 3, 4, 5. And the proposed ruling is to move cannabis products from Schedule 1, no medical use, and potential for habituation or addiction, to Schedule 3, which means that it has some medical use as defined by others, really initially, most recently by the HHS secretary, encouraging DEA to deregulate. As a result of that, we have the recommendation, and I really haven't found the direct source of that, although it's probably the DEA that said, we're going to move it to Schedule 3. I was on a call this morning with a group of lawyers discussing this issue, and here's the problems that it presents. One, that it looks like there would be no recreational use of marijuana provided under the law. In other words, you'd had to be a registered DEA registrant, which includes physicians, pharmacists, et cetera, or pharmacies, to purchase and dispense any controlled substance including those in Schedule 3 as proposed for cannabis. So how would this work? Well, pharmacists could buy, like they can now, belladonna powder or opium powder or marijuana powder, and use that to make various compounded issues. Why is that important? Because the FDA, to approve a drug, needs to go through the drug approval process. That is not likely to happen in the near future. It could happen within a couple of years, but could be as long as 10 years before that happens. So it looks like to me that from a dispensing point of view, the pharmacist will be dispensing compounded products, meeting individual patient needs, and all the requirements that pharmacists are well aware of, i.e. that you can refill the prescription up to 6 months. In California, you can't fill more than 120 doses. Even if it has refills, you can't exceed that a level. So there's some additional controls that occur state by state. So the current situation is that moving to Schedule 3 will require a hearing for rulemaking, as posted yesterday in the Federal Register. That hearing should occur, or be set rather, in 30 days. The hearing should occur within 60 days. We should have a potential ruling in 90 days. Why? Because the expedition requirements associated with the election. Because the election and Biden in particular, as you well know, has proposed that Schedule 3 be the new schedule for marijuana. So physicians writing for a prescription could write for the prescription, but they'll have to tell the pharmacist what they want in terms of concentration. Pharmacists will need to source the preparations to compound a particular dosage form. And until a drug is approved, in addition to what we already have in the cannabis space, Epidiolex, et cetera, it will take that for pharmacies to begin to dispense Schedule 3 drugs. That's all I have at the moment, Leah.
Well, that was a ton, and there's so much ground to cover, but I think that was a really amazing synopsis of what the history is and what the landscape is. I think a couple things that stand out to me are, number one, that this is an acknowledgement that cannabis medicine is indeed a medicine, whether it's addictive or not, or whether it should be controlled or not. But at least this is to a point where we're acknowledging that marijuana, just because it's a high THC variety of cannabis, has a medical benefit. And I think that's probably the most exciting thing for me. But I don't know if, this isn't really what the Biden campaign went for, which was full decriminalization. It doesn't sound like that's what's happening here, Paul. So those are sort of two key points that resonate with me.
You're right on, Cody. No question about that. And it is true that the Biden administration was looking for decriminalization. They were looking for changes to the banking laws. However, as I read it this morning, there would be no interstate commerce. So that is one thing that would not occur under the proposed regs.
Thanks. Thank you so much, Paul, for that information and for going over. Does anybody have any questions for Paul about the general background of that question? Anybody? Okay. We're going to move on.
I do, Leah. So
go ahead, Karen.
Paul, so Paul, then really the only way to access this would be as a result of a prescription from a physician. None of that direct pharmacy provision.
That is correct, at least at this point in time. Now, remember that pharmacists can obtain DEA licenses.
Mm-hmm.
So to the extent that they can prescribe, this drug could be prescribed using their DEA license.
Okay.
Those details, however, have not been worked out.
Okay.
You're muted, Leah. Thanks, Jill. Any other questions for Paul? Okay, if not, we're going to move on actually to the next question, which is, why did the FDA recommend moving cannabis from Schedule 1 to Schedule 1? And Carrie, would you like to take this one?
Yeah, well, and you know, it's been touched on and by both Paul and of course just a moment ago Cody about you know why they recommended moving from Schedule 1. Well, you know, first and foremost, as Paul had mentioned, Schedule 1 means that the particular compound has a high potential for abuse, has no currently accepted medical use, and there's a lack of accepted safety if you do choose to use it. So what I think is very helpful is when the FDA made the recommendation to move cannabis from Schedule 1 to Schedule 3, they looked at a lot of data, right? Now, when it comes to a drug or a substance that has a high potential for abuse, well, what do we know? You know, you could put a mouse in a cage, and that particular mouse is going to have a conditioned preference to utilize cannabis because it works, you know, by regulating dopamine in the reward pathways. And so those rewarding that action on the reward pathway leads to its possibility for abuse potential. But then, and then we see this in humans too. So it's not just mice in a cage. And we have longstanding data that show us that when people with cannabis, people who utilize cannabis, what is their risk of developing perhaps a cannabis use disorder? It's been pretty consistent over time, you know, running around 10%, let's say. Some studies will say a little bit different, but let's just say 10%. But then when you look at other substances that are not in Schedule 1, such as alcohol, such as tobacco, right? These have higher dependency risk ratios, you know, closer to 30% when people utilize them. There, of course, the possibility of having leading to abuse is higher for, let's say, oxycodone, right? Which is a Schedule 2 drug. It's an opiate. So what the FDA did is they looked at all these different data. The data have been collected by many different groups of people and researchers, public health institutions, and said, listen, it's consistently been shown that cannabis does not have a higher risk of abuse, right? It has a lower risk of abuse than these other things that are in, let's say, Schedule 2 or not even scheduled. And so there wasn't the rationale to keep it in Schedule 1 anymore. The second part, remember there's 3 parts to be Schedule 1. The second one was having currently accepted medical use, right? And what I think that it's interesting here is the FDA kind of had 2 factors that it looked at currently accepted medical use. Number 1 was the factor of just looking at physician utilization and recommendations of cannabis nationwide and looking at the statistics from the medical programs in the states that have allowed that. So what you see is an increased acceptance by the prescribing community to utilize and make recommendations for cannabis. So you can't say, well, there's no currently accepted medical use when, you know, a groundswell of clinicians are starting to recommend it and trying to use it in order to manage different disease states. So that was part 1 of the FDA's rationale. Part 2 of the FDA's rationale had to do with the scientific literature. What are we seeing? We're seeing more and more studies that actually demonstrate in a pretty good fashion that cannabis can be very pharmacologically helpful for things like pain, for nausea. And of course, more and more disease states are being studied. Although I have to tell you, it's really interesting when you look at more than 5,000 studies out there. Unfortunately, a lot of them have not been well designed to give us really great answers on, you know, this is exactly how you use the cannabis to lead to the outcome that, you know, would work for most people. So it still kind of remains a kind of trial and error as far as evidence, but you certainly can't say that there is no currently accepted medical use based on the scientific literature as well. So for part two, there was those two reasons why the FDA said we can't say it doesn't have a currently accepted medical use. And then the third factor that determines if a drug is in Schedule 1 has to do with the safety of it, right? So this idea that if, you know, you could use a drug, and I think we kind of think about risk versus benefits for drugs like who would be used for oncology, right? If you have a cancer, you're willing to utilize a drug that's much more toxic because the cancer could possibly be, you know, life-threatening disease state for you, right? So we're always kind of looking at the medical risk versus benefit ratio of different compounds. And for years, the thought was, no, the risk is just too high to utilize this product. And I think a lot of people had problems with that because they're like, wait a minute, isn't cannabis a really safe product? So again, what did they do? They looked at all the different public health data. They looked at emergency room visits. They looked at patients that had unintentional exposures, like kids that got in contact with gummies, things like this that lead to, you know, bad outcomes. And the reality is when you look at those emergency room department logs, when you look at information from the Poison Control Center, hospitalizations and things like that, that when you look at cannabis compared to things like heroin, benzodiazepines, cocaine, and other things, that cannabis was always the lowest on the list. So why was it on the same Schedule 1 when they have plenty of evidence now demonstrating that these other compounds, it's not like it? And so therefore that was the rationale again to deschedule it. So I think that you know, I thought they did a really nice job to look at different databases, different you know, evidence to really tell us, hey, this drug does not belong in Schedule 1. Now, you know, we can make lots of arguments. Does it belong in Schedule 3? But at least this was their rationale for moving it away from Schedule 1.
Yeah, I have to be the counterpoint, and I would argue that it doesn't belong in Schedule 3, and it's actually to the point that you made, which is the benzodiazepines, which are all existing in Schedule 4, which from a regulatory perspective is really no different. A Schedule 3 versus Schedule 4 from a pharmacist's perspective is the same rules. It's wrong from a anecdotal and evidential perspective, meaning like we know that benzos can cause more societal harm, more overdoses, more addiction, more withdrawal. We know this, right? So it's a little frustrating, you know, as someone who's really like dug into trying to be like part of like the cannabis culture, to be like, oh no, we're gonna settle for Schedule 3 based on the evidence, even though we know, yes, there is a potential for abuse, but cigarettes are unscheduled and they have more abuse potential with a exponentially higher potential risk of cancer. So I'm conflicted. Schedule 3, like, yes, pharmacists now get to touch this and there's like this benefit to me, but as someone who sees cannabis for a plant and not for some sort of narcotic that needs to be put on a schedule, I find this decision frustrating. And again, I'm always here just throw in my opinion. Sorry.
No, you know, but notice what I put on the title of the slide. I didn't want to like say that I was advocating for Schedule 3. I'm just saying, hey, why did they move it from 1? Because we know 1 was absolutely wrong.
Absolutely. Thank you, Carrie. That was awesome. And thank you for the conversation about it. It's really good to know specifically about that. It looks like we might have actually a question. Let me see if I can access that. Nope, it was just agreed. Awesome. Yes, and I think a lot of us do believe that it maybe should be considered to be a different schedule. But again, you know, we have only what we can deal with so far. And actually, Jill, later on, will be going over how you can actually provide this type of information to the government. So we're going to go to the next question, and I think somebody might be unmuted, so let me just take a look. Okay,
Me
so
this time.
so the next question is, how will patients continue to have access to non-FDA approved medical cannabis products? So I'll go ahead and I'll take this one. The biggest thing to remember about this is we really need to strive that current patients continue to get access to their medical cannabis. And that's so important because, I mean, that's the biggest thing that we might run into with Schedule 3 is that if we do not explain to the government that people need to continue access, we might be stuck with only FDA pharmaceutical approved cannabinoid products, but we know that that can take years to develop. So we really want to continue access. So under this new model, how will patients get access to the products that are currently on the market? Obviously, once they've been reviewed for safety. And the way that they would do it is it would actually be through a pharmacy, but there is actually a regulation that, like as most of you know, like for example, Sudafed, it's a drug that is obviously controlled because you need a sign for it at the pharmacy, but it can be given by a pharmacist. It doesn't need a prescription. So that's exactly what we're thinking here for Schedule 3 is that it would be products that would be sold at pharmacies by a pharmacist, a licensed pharmacist, and it would be products that already exist on the market. Again, there would have to be some sort of some sort of federal testing. Most already go through this for dispensaries, but some sort of federal testing for all access for these products to be at the pharmacy. So again, the goal is to not have to have, we don't currently have a prescription model for cannabis. And as we know, cannabis can be used in many different ways and not all the cannabinoids are beneficial. Some people have issues with THC, some people have issues with CBD, and so on and so forth. So really, our focus is to make sure that patients continue to get access without the need of a prescription, but it would be through a licensed pharmacy or a location that has the license for a pharmacy. And it could be liquids, and it could be edibles. It could also even be flour, but really, that's something that would really need to be discussed. And again, that's something that we will discuss more for what you want to provide to the government for public comment. So any questions about where you would be able to access your medical cannabis before we move on? I know that was really fast, but again, that was pretty brief. The other stuff is really important. I want to make sure we get there. Yep. Okay, Brandy, you have a question?
Yes, hello. Good evening, everybody. I wanted to, okay, I know they haven't had any type of plan or any type of blueprint for patients and pharmacists themselves. And again, we're still on Schedule 1 with the cannabis regulations, totally understandable. Now, how can it be a one-on-one communication within the patient and the physician itself for a specific ratio, like just for them themselves?
So what do you mean? Yeah. So the idea would be in this model, the doctor wouldn't write for a ratio. They wouldn't write, the patient would go into the pharmacy and explain, I am looking, I like to use a medical cannabis product, or I'm currently utilizing a medical cannabis product. It has this much THC, this much CBD, so on and so forth. And then the pharmacist from there would say, okay, here are the products we have. This is what matches, or based on your ailments, this would be the best option for you to start with, and this is how you would titrate up. But again, with that, I don't know if I really answered your question, Brandy, because really we're trying to get away from ratios, because ratios really don't mean how much you're actually taking. Because a ratio, if it's a 20-to-1, it could be 100 milligrams of CBD to 20 of THC. And we don't want to do that. We want to make sure we know, actually, I probably did that ratio wrong. But we want to make sure that we are getting the specific, just like any medication, we want the specific milligrams for each. So we're trying to actually move away from the ratio model to really specify which cannabinoids at which milligrams the patient should be using. So if the doctor does provide instead of an actual hard copy prescription, they would provide more of I would like my patient to be on a product with this much THC, this much CBD, this much, so on and so forth. And then based off of that, we would use the products that are available at the pharmacy, which meet those criteria. But it wouldn't be something that would be like specific, like it wouldn't be like, I would like care by design. So the patients don't need to rely on a specific medication to still get the type of therapy they want. Did that help, Brandy? I just want to make sure I fully answered your question.
And-
If not, I want to make sure I
Leah, do you mind if I jump in?
Yeah, please go for it.
Because I'm going to at the end, I'm going to go over what our legislative position is and what we're proposing as a thought of how we can direct this traffic. So I will outline that in a little bit.
And Natalie, I totally agree with you. I prefer care by design. I wish everybody would use it in California. Actually, I actually think it's a great product company and they should use it throughout the country, but that's just my 2 cents. No, actually, so that's a good question, Pam. Pam had asked, or Dr. Tarlow had asked, if it is Schedule 3, we wouldn't be able to do it this way. And that's actually not true. There are many medications that are controlled or that are monitored that the pharmacist can provide without a prescription. And there's actually legislation for the administration, for the dispensing of controlled substances up to 270 mLs. Again, that would obviously have to be, figured out and adjusted. And that's why it's important to do public comment. But but due to that federal law, it actually allows substances that are Schedule 3, 4, and 5 that are not FDA pharma products that are FDA approved to be dispensed by a pharmacist up to pursuant to the pharmacist's knowledge and and comfort with the dispensing of certain medications. So it actually would allow us in Schedule 3. This would actually allow us, as long as it's sold, but as Paul mentioned, as long as it's sold at a pharmacy or by a pharmacist with a DEA license to dispense the medication, then it can be done without a prescription from the provider. And that's another thing that Jill, I think, is going to go over during public comment, because again, that's another thing we want to push for, is because we don't want to have to wait for the FDA to just approve these things and to have only providers be able to write for these meds. We want patients to still have a lot better access, but with the ability to speak with professionals that can help guide them to the best therapy for them.
Yeah, I definitely have some answers to some of the questions in the chat. So we can wait until we finish up if you want, and then kind of follow up on all those questions.
Yep. And then there was another question about if researchers are still elucidating which doses of which cannabinoids, how realistic is it to expect your everyday recommending doctor or pharmacist, no offense, to know those ratios and doses? So, and that's another, again, and that's another thing Jill
No offense.
That's another thing Jill would be going into.
We have some thoughts.
Yes, because again, we do have suggestions for those at the pharmacy. If it's Schedule 3, they're going to have to be through the pharmacy. There's no way around that. So, because that's just what Schedule 3 means. But we are recommending that, education be included in this and not just general. And again, Jill will go over that. So I'm going to move on to the next question, actually, which is what might be required at dispensaries with cannabis rescheduling. And this is going to go to our good friend, Dr. Cody Peterson. Take it away.
Well, I feel woefully unprepared for this question. Look, I think it's complicated, and what might be required at dispensaries could go a lot of different ways. I think acknowledging that we don't know what's actually going to happen, and there's ways that we think pharmacists could get involved in this situation, and there's ways that Jill's going to lay out next, like how we might position a pharmacist to help patients while not necessarily restricting access. And I think that that's a super important point to be made. What might be required? Well, let's just put it this way. Right now, any other Schedule 3 substance that you are dispensing, you need a DEA license. You need a physical count of that your C3 inventory, and all. You need to have a regular audit of where these total amounts are going. So it'd be very strict inventory regulation if dispensaries were to comply with DEA regulations. Now, again, we don't have the answers, but I think that there's a real point to be made around the fact that it is potentially more than likely that because of, sorry, I'm outside, you'll have to forgive the noise, that because of the Schedule 3 status, but the existence of existing state markets with profitable tax margins, that we have no change in the access to cannabis in people seeking adult use cannabis medicine. But what we definitely will see if we get this Schedule 3 is this entry point on the medical side, is that there will be some sort of hole to create a space where patients can now go. They can talk about insurance, they can talk about whatever. So I think the most likely happenstance is that DEA doesn't touch these state-run programs. The Rohrabacher-Farr Amendment, for those who aren't familiar, this is a rider amendment that was passed in towards the end of the Obama administration, has continued onwards. It's the reason we don't have bus at dispensaries anymore. So Rohrabacher-Farr has prevented federal money being spent on, going against state laws on medical marijuana and recreational marijuana. I think as long as the political winds continue in that direction, we won't see any change to this, and we can see this growth of a medical model while still allowing cannabis to be moved to dispensaries. And then for when it goes to pharmacies, the people before me already sort of explained like how that might happen. So I hope that answered the question, and I really want the audience to feel empowered to speak up. It's okay if you want to hold your questions till the end, but I really want to hear your take. What are you concerned about? How can we make this space better? Not just like how can we accept Schedule 3? How can we make Schedule 3 something that serves patients? So thank you, Leah.
Thanks so much, Corey. That was great. And I just wanted to mention too, this is another thing that Jill will be going on in the next question, because again, we want, you should speak up. That, like Cody said, speak up, speak your mind, and make sure that if you want to make sure dispensaries still exist, you need to make sure that's put in the public comment as well. So we're going to go into that. Before we move on to Jill, we're going to go and get we have a question from Ayas. So go ahead. You can unmute and ask your question.
Hi, can you hear me?
Yes, go ahead.
All right. Well, it's just something that I've heard a couple of times mentioned already, about a patient walking into a pharmacy with the doctor that says, I want you to go and get this particular, combination or product or whatever. But this all presumes that pharmacists can prescribe, and we don't have prescriptive authority. We only prescribe under protocol. So there needs to exist either a collaborative practice agreement or a statewide protocol that governs our ability to prescribe these products, be it Schedule 3 cannabis or any other product, be it scheduled or not. So I just wanted to put that point out there that, we don't want to be missing the fact that we cannot be prescribing any product.
So actually we can. We're not prescribing it. We're dispensing it. So it's actually allowed in pharmacies. There's actually a law that allows pharmacists to dispense Schedule 3, 4, and 5 medications that are not a pharmaceutical drug. So there's actually a law that allows us to dispense that. And that's why we're allowed to dispense PEP and PrEP without a prescription. So
that's because there's a statewide protocol in California that governs that.
Correct. Yeah. So, but it's actually federally that Schedule 3, 4, and 5 are federally allowed to be dispensed by a pharmacist, not prescribed, dispensed by a pharmacist at a licensed pharmacy for medications that are substance 3 that are non-pharma. So technically all the products currently on the market that are cannabis would all fall under this, and they would all be allowed to be at the pharmacy, and they'd be able to be dispensed by a pharmacist without a prescription. It's a dispensing law, not a prescribing law.
Okay, but you need a prescription in order to dispense something. But we can talk about this later.
Well, there's actually a law, and Carrie, if you would like to go into it, if you feel like it. So there is a law, and that's why, for example, you don't need a prescription for PEP and PrEP, even though it is required normally to get a prescription. But in California, we can do it as a pharmacist. So again, yeah. So it just has to do with the regulations, and there are regulations that do state that if it's not from a pharmaceutical company, that Schedule 3 to 5 products can be dispensed by a pharmacist up to 270 ml. It's actually a federal law that many of us, I guess, didn't know about for a while that we just recently noticed. And it's like, hey, that helps. So anybody else? Any other questions? Okay, we're gonna move on then to our next question. Our next question is a long one, and Jill has lots to tell us about it. It is, what information should be provided to the Department of Justice during the public comment period, which is right now, it just actually opened, I believe, yesterday, about medical cannabis legislation and the transfer of cannabis from Schedule 1 to Schedule 3. So Jill, it is all you.
Okay, thanks. So, you know, there's another take on all this. You know, as we look at this, there's one viewpoint, which is very technical. Schedule 3 is exactly how Paul stated it. It requires a prescription for one person by a provider. And what has to be dispensed is an FDA-approved drug, of which we have 2 right now. We have Epidiolex, and we have, well, which is, you know, not scheduled, and we have dronabinol. Those are the only Schedule 3 cannabis drugs. But I don't see it like that, because I don't see how the FDA, with all of their reviews, they reviewed some of the studies with dronabinol, but they also reviewed the currently accepted medical use of cannabis from all sorts of walks of life, from dispensaries as well as dronabinol. So they're saying that medical cannabis use is effective and there is some efficacy. So I don't see them, they didn't say, okay, whatever, let's just put it in, Marinol is Schedule 3, so let's just leave it at that. That's not what they said. They said cannabis, which does not mean Marinol. So I see that as a conflict in Schedule 3 as it is today. I do not think by any means that they will shut down dispensaries in the rest of the United States. There's just no chance. It's the industry is huge. It's powerful, and the enforcement, can you imagine what that would look like? They can't even enforce the illicit market as it is. So I don't see that happening. I see it either they are going to go very strict and say, this is Schedule 3, meaning you can prescribe dronabinol and there's no state-run dispensary, or they're going to do something different. And so we have some proposals about what that might look like. And I think that we can help direct this. So yeah, nothing is in place about how we want to see things done, but why can't we ask for it? So we put together a cannabis legislative position. We're working with ASHP, CSHP on this, and hopefully some other folks. And in general, I'm not going to go read the whole thing, but in general, what we want is we want patients to have access to safe, reliable, consistent products as we move on. And we want pharmacists to be in charge of this. So we want pharmacies to, one of the questions was about education, and we have some thoughts on that, because the pharmacists have to be educated. That's a primary concern, and they need to be knowledgeable about the use of cannabis. Products is where it comes in a little confusing. But first, I'm just going to say that we could request that this is totally new. This is not like any other drug that we have. We already know that. So cannabis, why don't we?
Hey, let's do this thing around November and do something else for the, the health information.
Okay. So what we could do is we could have 2 models. We could have Schedule 3M for medical model, Schedule 3R for recreational. We're as pharmacists, we're not really concerned about the recreational. We're going to let the states take care of that. I think that's what it's going to be directed towards anyway. But we can be in charge of the medical model, which is perhaps this is now goes to pharmacists. So order, prescription, whatever you want to call it. Cannabis will be dispensed by a pharmacy and either ordered or written, for a patient by a pharmacist who is knowledgeable on this topic. So that's kind of how we see it. It won't be a prescription per se, but it will be, documented and order and count that the patient will be canceled by the pharmacist. So that's kind of how we see that rolling out. So two other parts before people can jump in. Sorry, I'll be quick. The product part is tricky. Where do we get the products? So one thought is that we could do like some of the states, the Georgia model in particular, where we have FDA pharmaceutical grade inspected manufacturers that provide to this medical model of pharmacy. And then there's specific products. I can see personally, I can see standardized products where it's, certain milligrams of, or what have you, THC or CBD or both, or and then I could also see a second model of compounding available. And as pertains to that, I can see education being provided in 3 different tiers. First tier, simple, 1 to 2 hours. Anybody who wants to just learn overview of cannabis, great, that's fine. Number 2 tier is if a little bit more intense, maybe 4 to 6 hours, and then you can dispense medical cannabis. You can be one of those providers of the standardized products that are available. Tier 3, you learn how to compound, and then you can also dispense, but maybe some of the compounding. I mean, I'm just winging it, seriously, but I think that Schedule 3 also opens the door for insurance so that pharmacists can be reimbursed, and patients. Who's the biggest consumer right now in these dispensaries? It's older adults who need guidance from a pharmacist and who are, by the way, having trouble. The ED visits are increasing with the edible. In Canada, a study just came out today where it showed that the legalization of the edible products increased ED cannabis poisonings, they called it, in Canada in their, sorry, I lost my train of thought. But anyway, what we want to do is we want to keep these folks safe. And I think this is a decent model that we can propose. And what if it all goes to the state? So the feds say, this is great at Schedule 3, each state do your own thing, which they could do. Then we need to make sure that our state takes this into consideration and authorizes us to prescribe or, be the orderer and the dispenser. Anyway, those are just some thoughts. We definitely want to provide public comment to the DEA, and why not try to change the model from what it is? And also, the cannabis nurses, thank you for asking that. I'm sorry, I'm just going to jump in again. If there are cannabis, I still like the idea of it being dispensed from a pharmacy, and if it's Schedule 3 in particular, that sort of fits into that framework. Any cannabis provider right now, including nurses, can write an order, take it to the pharmacy where they can rely on that pharmacy to give them what they want, rather than relying on a dispensary where you can just make a recommendation and send them off on their way. So I think that still fits in with the model and helps keep the patient safe and gives them a consistent product that is reproducible and they can find over and over again.
Awesome. And just to remind everybody, public comment is open for 60 days. It started yesterday. So remember, if you want to get in your public comment, make sure to get it in within the next 60 days to be able to, provide comment to the government about how you should see this, how you feel this should go. And okay, so now we're just we're open for just general comments, questions. This is the access for our website and how to get in touch with us if you guys have general questions. But we're happy to just open it up and, you know, raise your hand or put a question in the chat if you have one. And we're happy to, you know, to go over anything.
I see a lot of questions in the chat talking about cannabis nurses, and I think the cannabis nurses have an important role, but I don't know if it's my job to declare where their role is going to be. I think that collaboration is very needed, and I wanted to just throw that out there. I saw some nurses chiming in, and I really appreciate you. I think right now, sorry, I can do some video. I think right now the biggest need, or like the best place the cannabis nurses can help us, is like end of life care. I think that there's a huge need for cannabis and end of life care. Oh, I thought I had my video on. Sorry, to really make an impact in like actually administering cannabis instead of opioids at the end of life. And I think there's a huge need and a huge opportunity for nurses, because pharmacists can help facilitate that, but it's nurses at bedside. And as we move to long-term care, especially in the state of California, we have nurses who are going to be administering cannabis. I'm trying to implement something at my own hospital where we're having nurses, you know, document when patients give it, or patients self-documenting, and the pharmacy helping facilitate. Like, it's going to take a collaboration. It depends on the setting, but there's a huge need for nurses to be knowledgeable, for nurses to understand how we need to be tracking this and to be engaged in this space. But I welcome collaboration.
I feel that the nurse, I mean, nothing against providers. Providers are great, but I do feel that cannabis seems to be kind of pushed by nurses and pharmacists mostly. So I just think that it's really important that, like Cody said, I think the pharmacists and nurses need to keep the collaboration up and pretty much, you know, work with each other to get the best care for their patients. Because I agree with Cody, if we can make it the model where you don't need a prescription, then I think a nurse that works with cannabis patients should put down, you know, the information they want their patient to be on, of which types of cannabinoids at what doses, and then that way to make sure that their patients are getting specifically what they want them to get. So I actually think nurses are very important in this, especially because they've been such a force to be reckoned with in this fight to let medical cannabis become available for patients. So I think it's a great fight, and I think that a great, you know, push. And I think that we just need to keep collaborating together to fight for patient rights, really, more than anything, for those who do want to be involved in medical cannabis for their patients that are healthcare professionals.
May I ask a question? Is from the nurses who were on the call, is there any collaborative effort to write something for the DEA public comment, advocating in any way that you know about? I think the DEA is going to be bombarded with comments, but why not?
I would imagine that the ACNA would make a public comment, to be very honest with you. I know that I am lumping with my group out of, I mean, I know they made a position statement, but I don't know. I haven't seen anything coming out saying that they've made a public comment yet. I mean, I know me personally as a nurse, I'm making it with a board out of, you know, other board members out of Oregon on a board that I'm on. So, but I have not seen any emails coming from the ACNA at this point, gathering support for a public comment.
Alicia, rally them.
I mean, I'm not saying it's not being done. I just have, I mean, I just have not seen
I think
it
that
yet.
there's a huge opportunity for nurses. I'm sorry, if there might be noise. There's this amazing opportunity because of Schedule 3, because now nurses can handle this substance. It's no longer this taboo, and you're going to lose all this funding. So like we can now integrate into policies in states like California, who have already integrated like hospital-based care. Like, it does improve access to a lot of people based on current regulations, at least in California. But like, you know, a lot of the times these regulations sort of trickle down. And so I think we're going to see a normalization. And if under Schedule 3, hospitals will start saying, okay, you can bring in your medical cannabis. And that would be huge. And nurses would be administering that potentially.
Yeah, I mean, and let's be honest, and long-term care would be absolutely, you know, one of the first places that most people would love to see it. Hopefully in a hospital. I mean, we all know that in hospitals you can have long-term care, but You know, not quite like a nursing home where you go in and, you know, no hopes of coming out.
Hello, yes, I wanted to speak on that part as well. Yeah, I'm a little nervous. Okay, cool. But I know some of the nurses can try, or okay, you know what? Forget that. I want to get straight to the point. Without any pharmaceuticals or any like a slip to be given for debilitating or degenerative patients, especially those that are in the specific care to where they're not going to be able to sustain themselves, would that be considered a randomized control test, or would this be a real world evidence of how cannabis is evolving or not into a positive, more medicinal side?
I'm sorry, Brandy, are you asking about getting an FDA approved drug into pharmacies like the through the regular routes? Is that what you're asking? I'm not sure I'm understanding.
I'm just trying to figure out if
If the FDA will accept real world data.
Mhm.
But
They've
Yeah, I
made
mean-
that statement, yes, about cannabis. They actually, right after COVID, they made a comment that they, you know, with so many people trying so many different things and having and being able to look at evidence, I think this would be the wonderful opportunity to use real world evidence, because the biggest comment that they have about cannabis use and its current real world evidence is we don't know the denominator. A lot of people try cannabis, but we don't know how many people try and fail. And they want to know that. That's their biggest question about cannabis.
And the like what you just already reviewed, Carrie, is they looked at a lot of real world evidence to approve the change from 1 to 3 already. That was the entirety of that paper. So they're definitely going to accept that. Exactly what that'll look like, I don't know. You know, as far as we'll have to see.
Yeah, so I mean, and just to reiterate more, Brandy, I mean, this is this is pretty much a done deal. Like that's what they're thinking they're gonna. It's not that they need proof to make it Schedule 3. It's more just what do they need to know about, what is your opinion about them moving it to Schedule 3 as far as is kind of more what they're looking for at this point. But I don't think that there's any information that will prevent them from going from 1 to 3 though, if that's your question.
Yeah, well, no, we're good. I believe you answered it. Okay.
Yeah, if you have
I'm
any
good.
others, feel free to post in the chat or speak up, whatever you prefer. Okay, so we're down to our open comments. So does anybody have any just questions? Maybe something we didn't go over, maybe something that maybe people haven't thought about, or just anything else about. We've got about 5 more minutes before the end of the presentation. So I figured in the last 5 minutes or so, we can just see if anybody has any more questions about just in general about if cannabis goes Schedule 3, which it most likely will, if not descheduled, but most likely descheduled.
I got something again, sorry. I say that I recommend that everybody on this call make friends with their local legislator, because they need to know what we're talking about today, and if this is a statewide directive, then they can help with that. So you know, just try to meet up with your local representative and make yourself known.
And just as a reminder, this recording will be posted on the PCCC website for members. So, and also all of our old recordings that went over many different aspects about cannabis use for patients, including for pain management, as well as other topics, will also be on the website. And members get all access to all past recordings. So feel free to join and collaborate, and we'd love to chat with you. It looks like we do have another question. Yep, thank you guys so much. And again, if anybody needs anything, our website is right here. It's info@pcccrx.org, Our website is www.pcccrx.org. It's pretty similar. So please feel free. We love to help. If you'd like to collaborate with us, if you want to ask us what we're doing for a public statement, just let us know. Our goal is really just to make sure that we get the best information to the government as possible, so we keep access available for our patients. Okay, well, it looks like everybody's all set. And if anybody has any more questions, feel free to send us an email directly. Otherwise, I think we're all set for the evening. So again, thank you all for attending.
Thanks for coming.